I'm going to start off when I first met this woman. At that time, she was 40 years old, and she was found to have a murmur at an outside emergency department. She was involved in a recent motor vehicle accident. That's how she ended up in the ED. The ED physician heard an audible diastolic murmur, and then in that context, she had an echo. I'll let this play. We've got 2D long axis, 2D short axis, color flow long axis, color flow short axis. And here are some other images from the apical window. Color flow. It's looking at the abdominal aorta and the aortic arch. So based upon the echocardiogram, the findings are most consistent with which of the following? A genetic aortic aneurysmal disease, Marfan syndrome, vascular Ehlers-Danlos syndrome, acquired thoracic aortic aneurysmal disease, or non-syndromic aortic aneurysmal disease. Oops.
She was how old again?
40.
40. I think the valve was tricuspid, don't you think?
Yeah. Okay, good. So most of you said genetic aortic aneurysmal disease. I think just based on the phenotype of the aorta, I think it's difficult at this stage to be able to pass out what etiologic genetic disorder she has. But I think the reason why most of you felt that genetic aortic aneurysmal disease would be the case, and this is why I would think so, is because it's really dilated at the aortic root, and the remainder of the aorta appears to be somewhat normal. When we talk about genetic aortic disease, aortic aneurysm and dissection have, as we have already learned, significant morbidity and mortality. We see over 10,000 deaths annually in the United States just from dissection or acute aortic syndrome. Genetic determinants are a major factor in determining aneurysmal risk. And genetic testing, as we've just learned, has evolved as a regular feature at many aorta specialty care centers, and it's actually incorporated or integrated within our clinic practice. So anatomic location is important. Over the last, I'd say, 2 decades, we've learned about the etiologic basis of aneurysmal disease, and there's certainly a distinction between an aneurysm that's seen in the thorax or in the chest versus an aneurysm that's seen in the abdomen. Abdominal aneurysms are more associated with the conventional risk factors of atherosclerosis and smoking. They are more likely to be acquired, and the individual usually has the typical cardiovascular risk factors. Genetic influence, however, appears to play a more prominent role in thoracic aortic aneurysms. Case in point, I was involved in the care of a gentleman in his 80s, known or thought to have acquired aneurysmal disease of the thoracic aorta. But when you look at his CT scan, there was not a lick of atherosclerosis. And the demarcation of aneurysm was in the ascending aorta by itself. And it sort of compels us to really take that detailed family history. Because if you go into that detailed family history and you look for sudden death, you may be surprised. So don't let age fool you into categorizing an aneurysmal disease in terms of acquired versus genetic just based on the age alone. When thoracic aortic aneurysms appear to be familial or genetic in origin, we can broadly classify them into syndromic, and these include Marfan syndrome, Loeys-Dietz, vascular Ehlers-Danlos, or non-syndromic. And really, the difference is the syndromic types of disease, you should be able to look at the individual, examine them, and look for features that tells you there may be an underlying aortic abnormality. In the case of syndromic aortic disease, Those individuals look like every one of us. You cannot tell just by the physical examination that there's something brewing on the inside. So how did we examine our patient? She was mildly hypertensive, wide pulse pressure, heart rate 82. She had, on head and neck exam, mild hypertelorism. She had a normal uvula, bounding pulse, displaced apex, loud diastolic murmur and a systolic flow murmur. She also had thin skin and striae. So off the bat, there are some physical examination findings beyond the cardiovascular system. What's the next best step in the evaluation and management? CTA, chest, abdomen, pelvis, surgical consultation, no further testing, initiation of losartan and re-image in 6 weeks, or genetics consultation and family screening.
This is sort of like a post-test question. Excellent.
Good. I would agree with that. I think in this sort of context, we really need to define the entire aortic anatomy or vascular anatomy. So this is a CT scan, and I'm going to let this play. So this is a 3D volume-rendered image. We turned our patient to the left side, and we're going to cut away to reveal the vascular structures. Here we're seeing the left ventricle, there's the pulmonary artery, and we're going to see the aorta coming into play. Aorta is starting to peek in here, and you can see this very asymmetric, severely dilated aortic root, but also notice the tapering towards a normal caliber ascending aorta. We're now in the short axis. We're entering the LVOT here, LVOT level, and I'm going to just move this across, and we can see the very asymmetric, severely dilated aortic root. And this again makes a point for the echo, or the not limitation, but the caveat you need to be aware of, that when there is asymmetry, it's going to be even more difficult to make that measurement perpendicular to blood flow and echo. As we move more superiorly, we can see how the ascending aorta and descending aorta have a normal caliber. And then we finish off the exam. Here we see that pear-shaped dilatation of the aortic root. This is her abdominal imaging, and I would bring your attention to other vascular structures. These are the internal mammary arteries, and they look a little bit tortuous and maybe ectatic. And we're going to take a look at her arch vessels. And just notice how tortuous the arch vessels, the subclavian artery are. So the tortuosity of the vascular structures is an important to the potential underlying etiology. See that real hairbend sort of turns in multiple blood vessels. Sorry, that was the chest. This is the look at the entire aorta, thoracic aorta, huge aortic root aneurysm, tortuous arch vessels. We see also dilatation of the iliac vessels as well. Another closer look at the aortic root, and just look at the tortuosity of the subclavian artery. Her aortic root measured 68 millimeters on echo, and it was consistent with what we saw on CT. So a question here, let's consider that we're dealing with the syndrome called Loeys-Dietz syndrome. Which of the following genes is most consistent with that diagnosis? TGF-beta receptor 1, fibrillin, Notch1, ACTA2. This is great. So very smart audience. Remember I said that on Saturday, right? So when it comes to the competition, you know who to vote for. Oops. In adult patients with Loeys-Dietz syndrome, the suggested dimension to consider prophylactic aortic root surgery is which of the following? 3.5 centimeters, 4 centimeters, 4.5, 5, or 5.5. Very good. So most people thought 4.5. So let's get back to our patient. So we had a clinical diagnosis of a genetic vascular disease. We suspected Loeys-Dietz syndrome based upon imaging findings, aortic root aneurysm, multiple areas of vascular tortuosity, as well as some of the phenotypic findings on clinical examination. At that time, genetic testing wasn't covered for her, so she did not undergo that testing. Her aortic root dimension was 68 millimeters, so she underwent prophylactic aortic surgery, and the procedure was an aortic root replacement with an onyx composite valve conduit and an ascending hemiarch replacement with a 26 millimeter Dacron graft. And this is just an image post-surgery. We can see the valve conduit and the post-surgical result. So let's talk a little bit about Loeys-Dietz syndrome. It's an autosomal dominant connective tissue disorder, first characterized in the early 2000s, which is aortic aneurysms, generalized arterial tortuosity, hypertelorism, and a bifid or broad-based uvula or cleft palate. It was first reported a genetic cause of LDS was related to mutations in actually several genes, but the TGF-beta receptors, 1 and 2, were causative at that time. Now, as opposed to Marfan syndrome, where we really looked at an abnormality involving the aortic root, with Loeys-Dietz syndrome, you can have aneurysmal formation anywhere in the vascular tree. This is a picture of her daughter, of my patient's daughter, who also has the diagnosis. I think the finding of bifid uvula helps you when it's there, but it's actually not as frequent as you would think in Loeys-Dietz syndrome. So the diagnosis reflects a combination of arterial aneurysm and dissection, or a family history of documented LDS, and now that genetic spectrum has expanded to involve 4 genes. The TGF receptor genes, SMAD3, and SMAD is a sort of a second messenger, as a subcellular protein that is involved in a lot of other pathogenetic mechanisms. And then TGF-beta 2. So what's our approach? Imaging surveillance is key. It's cornerstone. Prophylactic surgical repair at a lower threshold of intervention, because these patients can have a more aggressive course. We have to consider medications and lifestyle management, and then non-cardiac issues as well. Individuals who have severe craniofacial features, they're probably at a higher risk of acute aortic complications. And so think a little bit more closely about them in terms of when we time prophylactic aortic surgery. All individuals with LDS require echo at least annually. And again, this sort of highlights the importance of surveillance imaging. The decision to go aortic surgery is based upon multiple factors: the absolute dimension, rate of progression, aortic valve function, severity of non-cardiac features, family history of a malignant course, genotypic information, but a whole host of factors. Post-operatively, we do echo, 3 to 6 months intervals for 1 year, and then we can sort of spread that out to 6 to 12 months intervals subsequently. So now we fast forward 6 years. She's now 46 years old, and she undergoes routine surveillance with me. Clinical diagnosis is Loeys-Dietz syndrome. I can update that now. She actually has the genetic testing done, and she has the genetic TGF-BR1 mutation. Routine follow-up on yearly surveillance has really been largely unremarkable. And she's sort of been asking me, can we push things a little bit further now, because she's worried about radiation, she's worried about fair questions. However, at that same time, when I was going over the results with her, there was progression, unanticipated progression of aneurysmal disease in branch vessels. So I'm going to play this for you. I want you to pay attention to it because there's a question that follows. So looking front on, look at all the vasculature, including the ones next to the sternum. I'm really zooming up on it for you, just in case you miss it. And so now we're going to go into an axial view. It's the sternum. Just pay attention to the vascular structures alongside it. Just remember which is right and which is left. Okay. So in the interest of time, I've shown you the important diagnostic findings there. So the question for you, which of the following most accurately describes the imaging findings? Bilateral internal mammary artery aneurysmal disease, right greater than left, aneurysmal disease, bilateral left greater than right, bilateral right greater than left, but with dissection, or left greater than right with dissection. Okay. I can't even remember the images, to be honest, so let's go back and look at it. So this is the case, and here, this is her right internal mammary artery. It's actually got a complex spiral dissection. You can see thrombus on one side. This is actually not the largest diameter that we saw, but I think it showed the dissection flap in two places very nicely. And just look at the size of this vessel here. It's enormous. So indeed, she had bilateral internal mammary aneurysmal disease with multifocal dissections. So what do we do? To be honest, there's no great data. So what we do is we discuss in a multidisciplinary care conference. This takes place every Monday evening. Includes surgeons, our imagers, our congenital heart disease specialists, sometimes our interventional radiologists who came for this one, and our vascular medicine specialists as well. And then we made a decision by consensus. And so we considered coil embolization of the right internal mammary artery, and she underwent that procedure. In terms of the data, in terms of guiding our decisions, as I mentioned, there's really a paucity of data. Most of the data is for the large vessels, the aorta proper. But when we come down to the visceral vasculature, we are really hazarding a guess. We say 2 to 3 times the expected arterial diameter or observation of continued growth. I think this is the time when you really have to reach out to the experts in the field. And I have no qualms in reaching out to even our experts in different institutions. I sent out a note to Loeys Dietz, who's the authority in this disease process. And he's very inviting and very helpful in these sorts of circumstances. So this is how she looked after coil embolization. And you can see these extra dense areas is where the coils have been deployed. I'm just going to move this a little bit forward. We're going to see the long axis of the internal mammary arteries. with that so far. Having said that, this is unpredictable, and I think the biggest take-home for me was that you can go on surveillance imaging and feel lulled into a false sense of security, and then something can happen unpredictably. If you were to ask me, did she have any symptoms prior to this that could have led you to the diagnosis? The answer to that would be potentially. Every time we visit, she would have some palpitations on occasion or some chest pains that's nondescript. But even at those times when she had undergone imaging, we never saw this. So it really tells us how unpredictable and how little we actually know about the biologic sort of pathogenesis of this disorder. When we talk about medications, we use beta blockers to reduce hemodynamic stress. ARBs have a mechanistic benefit in the TGF-beta signaling cascade. And what I've been taught by Dr. Dietz is to try to get the highest level of losartan at the tissue level. So I go for the maximum dose tolerated. And she was already on the maximum dose tolerated, and despite that, she had vascular complications. Prophylactic medication should be considered for individuals with LDS, even without aortic enlargement, if they have an aggressive family history of LDS, if somebody in the family has aneurysm or a complication. LDS is beyond the heart and vasculature. These individuals typically have orthopedic issues that require attention, immunologic issues, asthma and food allergies comes to mind, and inflammatory bowel disease. Sleep apnea, they have a tendency for pneumothoraces, and other, I really need to highlight psychosocial and adjustment issues. Any one of these, every patient that I have with a genetic aortic syndrome, typically Marfan or oral LDS, I try to plug them in with the National Marfan Foundation because for them, when they get this diagnosis, it can be devastating. They feel alone, and that social construct that these foundations provide them is she tells me she has me on speed dial just because it's such an anxiety-provoking disorder for them. And it can be disruptive even for the family because now it's not only her, she's also worried about her children as well. Learning points. Genetic contribution to aortic aneurysmal disease is playing a greater role in our current understanding. LDS is a syndromic genetic vascular disease typified by arterial tortuosity, aneurysms, and craniofacial abnormalities. No 4 genes, TGF receptor 1 and 2, SMAD3, and then TGF beta 2. And these are all associated with LDS. And then remember the picture. It's a vascular disease that can affect all components of the vasculature. Mainstays of management, genetic counseling, family screening, imaging surveillance, and don't let your guard down. And then assessment for prophylactic aortic surgery. And of course, medical and lifestyle management. This is, you've bought the patient for life, and you're going to be there through their lives and through their children's lives. So it's an important responsibility.